Bismillahirrahmanirrahim. I welcome you all, and I'm thankful to the organizing committee for giving me the opportunity to deliver a talk on cryoablation for atrial fibrillation. This is our Department of EP, and it is considered to be the state-of-the-art center in Asia. We have two dedicated EP cath labs, two 3D systems, two EP systems, cryo system for atrial fibrillation, ice and carto sounds, cool tip and tacticians and smart touch technologies, and cardiac MRI and CT angio. We have the honor that we did the first ever cryoablation in our department in 2016. Well, atrial fibrillation is considered to be the most common clinically problematic arrhythmia because at time it ends up with thromboembolic stroke, and it increases the mortality by twofold. At time, it's very difficult to treat. The arrhythmia drug therapy is relatively ineffective with side effects and pro-arrhythmogenicity. The rhythm control should be more effective than the rate control. Atrial fibrillation affects 1 to 2% of the population, and its prevalence is estimated to be at least double in the next 50 years. AF is broadly classified into paroxysmal atrial fibrillation, persistent atrial fibrillation, long-standing persistent atrial fibrillation, the permanent one, and the last but not the least is the non-valvular AFib. The AF which terminates spontaneously within 7 days or with cardioversion within 48 hours, it is called paroxysmal atrial fibrillation. And the AF which persists for more than 7 days or cardioverted after 48 hours, it is persistent atrial fibrillation. And when there is a joint decision by both the clinician and the patient that no more restoration of the sinus rhythm is needed, then it's a permanent AFib. And AF, in the absence of rheumatic mitral stenosis, mechanical or biprosthetic or mitral valve, it is termed as non-valvular AFib. So this cartoon shows a beautiful demonstration of the normal conduction and the mechanism of atrial fibrillation. We know that this normal impulse generation takes place in the sinus node, and it goes through the AV node and then downstairs, creating a normal sinus rhythm with a P wave and QRS complexes. Contrary to this atrial fibrillation, there is disorganized electrical signals, and the mechanism behind it, there are certain foci which triggers disorganized signals. Later on, it was thought that there are multiple wavelet hypotheses, and that is called the rotors, which are responsible for the creation of these disorganized electrical signals, leading to fibrillatory waves and irregular ventricular rate. So this is from a paper of the Zahoor et al., published in 1998, who worked a lot on atrial fibrillation, that there are certain foci which are distributed both in the right and the left atrium. And in the right atrium, we can see that there are some foci in the superior vena cava, inferior vena cava, fossa ovalis, and the coronary sinus. 94% of this contributes from the left atrium, with a much more contribution from the superior pulmonary vein and a lesser one from the rest of the pulmonary veins. So we can see that here are the pulmonary veins, the left atrial appendage, and the left atrium. And there is foci which triggers the initiation of the atrial fibrillation, and there are some wavelets in the form of, these are called rotors, which are the main drives for the initiation of atrial fibrillation. This construct shows a beautiful demonstration between the relation of the time with the risk factors and then this development from the sinus rhythm through the paroxysmal, persistent, and the permanent AFib. And there is a time-dependent remodeling of the left atria, which leads to permanent AFib. Well, atrial fibrillation is a growing epidemic, and it is considered to be the most common arrhythmia, which affects almost 33.5 million population worldwide. And at the age of 55, more than 55, there are 1 in 4 persons who are having atrial fibrillation, and the prevalence increases with the passage of time. The magnitude of the problem is much more that sometimes the paroxysmal atrial fibrillation is unnoticed and it causes cryptogenic stroke, ischemic stroke, which leads to cognitive decline, end up with dementia. And also causes heart failure and sudden death. And if the patient is symptomatic with having tachyarrhythmias or hemodynamic instability like dizziness, lightheadedness, heart failure, and syncope, then it needs a medical attention. There is a set of populations who are having silent atrial fibrillation, which constitutes valvular heart disease, age more than 60, obesity, hypertension, heart failure, post-AFib and post-VT ablation, and devices. And one high point is that aortic valve disease itself does not cause atrial fibrillation unless and until it is associated with mitral valve disease. And in obstructive sleep apnea, paroxysmal atrial fibrillation is the most common arrhythmia. Well, every one of us has a 25% risk of developing atrial fibrillation, and age is a major risk factor, and the prevalence increases significantly as we grow older. And we can see over here that at the age of 60, there is 1 in 25 persons are having atrial fibrillation, which is increased to 1 in 10 at the age of 80. And the risk is increased if it is associated with hypertension, diabetes, coronary artery disease, obesity, and if the patients are smoker. Well, there is an algorithm for the rate versus rate control in patients with symptomatic AFib, though it seems to be a very busy slide, but it's very simple. That those patients who are having symptomatic AFib, first of all, attempt should be made with a rate control like beta blocker and calcium channel blocker. And if the symptoms resolve, then continue with the beta blocker. If not, then modify the rate control and we consider the rhythm control. If the patient is having paroxysmal AFib, then there is a low burden of recurrence, then we adopt the pill in the pocket antiarrhythmic therapy. And if the patient is having a high burden of recurrence, then we maintain the antiarrhythmic therapy. If no improvement, then we subject these patients to catheter ablation. Similarly, for persistent AFib, we consider the cardioversion, and if the patient is free of symptoms and the AF recurs, then we go and put these patients on maintenance therapy, and then we consider catheter ablation if it fails. Similarly, there are special circumstances in which we consider the early rhythm control, and these are the people who are having highly symptomatic with multiple recurrences, extreme impairment in quality of life, and arrhythmia-induced cardiomyopathy. Well, every patient who are having atrial fibrillation, and when they are diagnosed as a new patients, so if they are non-valvular, having a non-valvular AFib, then we put a patient on the vitamin K antagonist, and if it is valvular, then we measure the CHAD-VAS score, and then we put the patient on and NOx accordingly. Well, there is a 2017 APHRS consensus on the statement of for the catheter and surgical ablation of the atrial fibrillation. It says that if the patient is having symptomatic AFib refractory or intolerant to at least 1 class 1 or 3 antiarrhythmic drugs, then catheter ablation is recommended. While for persistent, it is reasonable, and for the long-standing persistent, it may be considered. Prior to initiation of the antiarrhythmic, some patients we subject them for catheter ablation, but it is a class 2A indication. There are different modalities used for achieving the pulmonary vein isolation, and the one is the radiofrequency ablation, the second one is the cryoablation, and the third one, which is under research, is the laser one. The most commonly used is the radiofrequency ablation and the cryoablation. And radiofrequency ablation, we use the radiofrequency current and in a point-by-point method to ablate that area which causes cellular necrosis. Contrary to this, in cryoablation, we use a cryo balloon and we use a refrigerant gas which freezes the cellular, causes cellular necrosis by freezing, and we achieve the pulmonary vein isolation. So the cornerstone for paroxysmal atrial fibrillation is the pulmonary vein isolation. And this cartoon shows the circumferential isolation of the pulmonary veins, which is by radiofrequency ablation. So this is a cryoballoon apparatus with a steerable sheath, cryoballoon catheter, cryoballoon, and the mapping catheter. How do we do it at HMC? We adopt certain steps for atrial fibrillation. First is the patient selection. The patient should be having paroxysmal persistent AFib. We should rule out the cardiomyopathies, and there must be a normal LA size. We do the CT scan to delineate pulmonary vein anatomy, and we do the TE to rule out LA and left atrial appendage clot. Then we go for venous SS and transeptal puncture, left atrial appendage and pulmonary venograms, pulmonary vein isolation with cryoablation, and then post-ablation anticoagulation. These are the steps of cryoablation. First, we assess the target vein, then we inflate and position the balloon, we occlude and ablate, and then we assess the pulmonary vein isolation. Usually, we discharge this patient within 24 hours after the procedure, and we ask them to follow up at 3, 6, and 12 months interval, and we do the ECG and the 24 hours Holter. And the patients are sent on anticoagulation for at least 3 months. Coming to the case, 45 years old male presented with a history of palpitations for the last 2 years, and he was labeled as having paroxysmal atrial fibrillation with a left ventricular ejection fraction of 60% and the LA diameter of 3.8 millimeter. Here is the ECG. First of all, we assess the venous side to look for the integrity of the vein. We can see that there is nothing wrong with the vein. Then we do the transeptal puncture, a little bit stain over here in the interatrial septum. We remove the needle and the dilator. Then we pass the LA wire. We dilate it with the dilator. We pass the steerable sheath. Then we do the pulmonary vein venogram to delineate the pulmonary veins in the left atrial appendage, especially because it is very fragile structure, the left atrial appendage, and at times it causes perforation. Similarly, we do the pulmonary venogram of the superior pulmonary vein, the inferior pulmonary vein, and on the right side, the right inferior pulmonary vein. Then we do the cryoablation, and we can see that there is inflation of the balloon with the cryoballoon catheter and the mapping catheter. Then we check for a leak, and we can see that there is some sort of leak over there. It means that the balloon is not in good contact with the pulmonary veins wall. So we push it a little bit, and then we can see that after injection there is no more leak, and we freeze it at a temperature of -40 for 180 seconds. Similarly, we repeat this procedure in the left inferior pulmonary vein, and similarly in the right side in the superior and inferior pulmonary veins. And then we observe on the monitor that there is disappearance of the pulmonary vein signals and reverted to the normal sinus rhythm. The most common major complications are pericardial tamponade, femoral access-related pericarditis, stroke, pulmonary vein stenosis, AV fistula, and in 3 to 8% of the patient, these patients develop pre-neck nerve injury, which is then recovered in 1 year. So the take-home message is that AF ablation decreases symptoms and AF recurrence, and there is an 80% chance success of cryoablation. And it's a safe procedure, and patients should be referred for AF ablation. Thank you very much.